is my pleasure and honor to invite our chairman, who is well known for everybody, Professor Amos Korczyn, to speak about medically unexplained symptoms. I shall not read the CV of Professor Korczyn because I know everybody knows it. What I want to add is something which is missing here. It's mentioned that you are the honorary member of Societies of Neurology from Israel, Serbia, Poland, and Russia, but I have to add that you are also honorary member of the Romanian Society of Neurology, which is not written here.
Thank you very much, Mr. Chairman, for the introduction, and I apologize for the mistake. I hope you will not find many more in my lecture now. Following these excellent talks by Antti and George, I want to go back to medicine and to discuss with you one issue, one topic which is for me fascinating and which is related to these issues that have been discussed by my predecessors. So medically unexplained syndromes. And of course, I would start with Donald Rumsfeld, who says that, as we know, there are known knowns. There are also things, these are the things that we know. But we also know that there are known unknowns. That is to say, we know that there are some things that we do not know. But, and this is the most important thing, there are also unknown unknowns, the ones we don't know. We don't even know that we don't know. And if one looks through the history of our country and the other free countries, it is the latter category that tends to be the difficult ones. So this is another aspect of the difficult question. So what do we mean by medically unexplained symptoms? What is the history? We know this long time ago, Les Malades Imaginaires by Molière, and then Daumier. But it's, and so there is a French important influence here. What's in a name? So what we call medically unexplained symptoms was called at different terms throughout history: hysteria, neurosis, neurasthenia, hypochondriasis, conversion disorder, somatoform disorder, and so on, a long list of parallel or overlapping terms, and I will use the medically unexplained symptoms as the most relevant ones to my talk. So in medicine in general, there are diseases like stroke or epilepsy, each of which may have different causes and different presentations. There are syndromes, for example, schizophrenia, which is, we don't understand what it comes from and how it comes from and what are the manifestations due to. And in addition to diseases and syndromes, there are the medically unexplained symptoms. So the scientific discussion about this, we may start this with our friend Charcot, again, an important Frenchman, and he demonstrated this hysterical behavior, hysterical women. And so behind Charcot stands our friend Babinski, who was his most important student. And Babinski did not quite agree with what Charcot was saying, and he insinuated, Charcot, that he caused these poor women to behave in such a way. And maybe he did, maybe he didn't. This is not the important issue. The important issue is that even if he did, even if there was the influence of Charcot to cause these manifestations, these behaviors, these were still unexplained how this was done. And among the participants here, there are several whom we identify. There are others whom we don't. But one of them was Sigmund Freud, and Sigmund Freud was very important also in the context that we're going to discuss. And also there was Axel Munthe, So those of you who have not read The Road to San Michele, and also those who have, should read it again with this issue in mind on how Axel Munthe was impressed and what was his severe criticism of the Charcot approach. So in modern theory, now we have, for a couple of years, we have what a psychiatrist called the DSM-5, these criteria for the what they call somatic symptom disorder, again an overlapping topic. So these people should have motor or sensory symptoms incompatible with we as neurologists can understand or explain, so not otherwise explained, and associated with distress. Associated with distress is mandatory. Is it really? Because for Charcot, it was label indifférence. So it's just the opposite of being associated with distress. These poor women were not distressed. In the label indifférence, a relative lack of concern about the nature or implication of the symptoms. So this brings this issue of medically unexplained symptoms a wider concept, because it's not just the people who come with complaints, there are also people who are indifferent to whatever happens. Let's move forward to the present, and there are several medically unexplained symptoms. People who come to general physicians complaining of dizziness, and they send us to us saying this is vertiginous, and we say, do you feel any rotation? They say, no, I just feel something strange in my head, I'm dizzy. And we don't understand this in most cases. Sometimes we find orthostatic hypotension or whatever, but in most cases we don't understand this. Fatigue or weakness. Why are you so tired? Was there anything wrong? Didn't you sleep at night? No, I slept very well. In fact, I sleep more than I should, and still I don't have any power. I'm still so weak. Headache and other types of pain. Sometimes, of course, we know what causes them, but many cases we don't understand what is the cause. And sleep problems. Why can't I sleep? I'm so tired. There are other medically unexplained syndromes, which we give them names. Systemic exertion intolerance disease, this is the weakness that they complain of, so we give it a name. Fibromyalgia, these people who complain about unexplained pain, we call them fibromyalgia, original pain syndrome. Tension headache, chronic low back pain, chronic fatigue syndrome. So we must accept that what we call medically unexplained symptoms is really a meta-diagnosis. It's not a single unit, because it has many, many completely different manifestations. The psychiatrists tell us we know what is the reason. Hysteria, they started off by believing or proving to some extent that it all comes from the womb. Then it turned out that men who are definitely wombless also may develop similar symptoms, so this was neglected. We still use the term, but we know that we don't really mean the womb. So then there was this term of hypochondriasis, so it's still below, in the lower half of the body, but maybe in the liver or something else that produces some substances that are going on in the body and causes the mind to behave in this strange way and produces symptoms. Or now we use the term supratentorial. I'm not sure what it means as a neurologist, about which tentorium and what is happening. And anyway, these are the terms that have been used, but these are not really explanations, of course. And of course, we use the term now of somatoform disorder instead of conversion disorder, but it's actually the same thing. What is somatoform? It's a conversion of the body thing to the mind. So it's the same thing, conversion disorder or somatoform disorder. We use modern terms, but the fact that we use a new term does not mean that we understand it better. For example, post-traumatic stress disorder. This had many different terms used in the American Civil War and then the First World War, and now after the more modern wars, post-traumatic stress disorder, and we'll come back to that. So I must stress that these are very common problems that we see. People who are weak for no reason, people who cannot sleep for no reason, people who sleep too much, people who have pain for no physical reason that we can identify, and so on. So these are major causes of referral to any field, from general practice to neurology, of course. But it can always be important because it's not just you can neglect and say, okay, who cares? This may be important issue. So if a person comes to the emergency room with a stroke, then we evaluate them as perhaps needing to get a TPA, and TPA is expensive and also dangerous, has significant adverse effects. So what if the patient does not have a real stroke? And maybe 10% in some centers are reported to have stroke mimics, maybe psychogenic, maybe psychological. So if we give them the TPA and they develop intracerebral hemorrhage, it's not so good. Or status epilepticus, which is again something which is serious and leads to anesthesia, sometimes emergency anesthesia. Definitely they need to be hospitalized in emergency treatment, which is okay if there is real seizure. But if it's not a real seizure, only a look-like, and this happens in every epilepsy center can tell you about such patients, and you give them general anesthesia, this is not innocuous treatment as well, and people have died because of that. So it's the medically unexplained symptoms are common, are expensive, and not always benign. So what do we do about this? How can we explain it, or can we explain it? So the diagnostic criteria say that we should exclude neurological disease, and of course we should exclude feigning. And the DSM-5 demands that we establish a psychological mechanism, but this is in small print, small letters. It's not mandatory. And I will come back to this issue of the psychological mechanism causing it. So basically, functional disorders, or there's another term for this, is a negative definition, lack of an organic explanation. It's not that we have a positive cause of it. We say we cannot, we neurologists, who know everything almost about the brain, almost everything we know, we cannot explain it. So what is it? How does it come about? Just a negative explanation is always dangerous. It's always dangerous. We should be very careful when we use a negative explanation. And again, I say that the establishment of a psychological mechanism does not usually occur. It's very infrequent to find the psychological mechanism or the assumed psychological mechanism, and I will mention this later. And I want to remind you that we should be modest, because I am probably the oldest person in this room, and I can tell you that when I was in medical school, duodenal ulcer was also considered to be a psychosomatic disorder, and people with duodenal ulcer were sent to a psychiatrist to relieve them of their symptoms. And of course, now we know, and there is a Nobel Prize that was given for the establishment of a medical cause. So we should be modest. The fact that we don't understand, we do not find the cause, does not mean that there is a cause. But this is a side issue, because we don't believe that in most cases we are going to find such a simple solution. Now, when we speak about organic versus functional, again, this negative definition, How do we know? So many neurologists will say that the people who have tension headache have a non-organic disease. Migraine, of course, is organic. Why do we say that migraine has an organic basis, whereas tension headache is functional? The main argument for migraine to be organic is the fact that we have triptans to treat them. There is nothing else there that proves this, had we not had triptans to say that these are different from tension headaches. And if somebody comes tomorrow with an agent that will relieve tension headaches, we'll accept it as an organic lesion. So again, this issue of organic versus functional. And again, pseudo-seizures are an important problem. And these people who come with the seizures and their EEG is normal during the seizure when you, for example, videotape them, these movements that they have during the seizures are evidence of muscular contractions. The muscular contractions come from the spinal cord. The spinal cord is dictated by the brainstem or I don't know where. And the fact that we don't see it on the EEG does not mean that there isn't some electric occurrences in the brain. Of course there is. So the issue of seizures versus pseudo-seizures, real seizures versus psychologically excited brain is a difficult issue. The psychiatrists again tell us, beginning with Freud, that these symptoms are aimed to resolve internal conflicts of the mind, not of the body. Or there is secondary gain, or now, more recently, that it's due to stress or depression. Maybe. But does it mean that what we call functional, non-organic, is really psychogenic? We don't know as a positive fact that it is psychogenic. These are all assumptions that there is a resolution of internal conflicts that is mediated by these pseudo-epileptic seizures or tension headache, that there is secondary gain, that there is stress or depression. It's just an assumption. So this equality of functional equals psychogenic, we have to think about it again. What is the role of stress here? If we take this last point here, stress. Well, we know that stress can cause post-traumatic stress disorder by definition. So this is perhaps the only psychiatric disorder where we know for sure what hit the bullet, what is the cause. It is the stress, post-traumatic stress disorder. But is it a stress disorder, or is it the post-traumatic stress which caused the disorder? Is the stress part of the initiation, or is it part of the mechanism of the ongoing disease? The first it started this way does not mean necessarily the stress is involved in the continuation of the manifestations. So again, I want to point to the dichotomy when we say that organic are neurological and functional are psychiatric. What do we say about pseudo-epileptic seizures or about post-traumatic stress disorders? Of course, in this disorder, there is something wrong going on in the brain. We cannot say that it's only in the mind. There is some brain activity which is ongoing there. Although in post-traumatic stress disorder, for sure, by definition, it started by stress. The stress caused this. So when we speak about depression and anxiety, the association does not prove causation. The fact that these people with what we call psychogenic seizures or what we call post-traumatic stress, or the fact that they are associated with stress does not mean necessarily that they are caused by stress. And For those of you who maybe do not accept that difference between association and causation, let me tell you about this study that has been done and published in the New England Journal of Medicine, where an investigator tried to see the correlation between chocolate consumption in different countries and Nobel laureates. And surprisingly, very surprisingly, there is a clear correlation between the number of Nobel laureates and chocolate consumption in each country. There are two outliers here. Germany, we know why Germany did not have as many Nobel Prizes in the 20th century as it should have perhaps had. So this is below the line, and which I can explain. I cannot explain why Sweden got more than its share of Nobel laureates. This is unexplainable. Anyway, the fact that this paper has been published in the New England Journal of Medicine did not convince any government to come up and give unlimited access to chocolate to the population in the hope that more Nobel laureates will emerge from it. So association does not prove causation. And depression and anxiety may not be the cause of the abnormal behavior. They may just as well be the consequence of this. If I would have seizures, recurrent seizures, psychogenic or organic, which our epileptologist will not be able to solve for me, believe me, I will be depressed, I will be anxious. So the fact that if we refer a patient to a psychiatrist and they say this guy is depressed or is anxious, does not mean that this caused it. Of course, it should be treated, but not it. So this is an issue of reverse causality. So we should be very careful about what the psychiatrists tell us when we refer these patients to them. So, as you see, a lot is still unknown. Nobody has ever told us why this symptom, why now, what happened that caused this, except again for post-traumatic stresses, although we don't understand why these people developed these symptoms and not other symptoms, and why this at this point in time or not. So, for example, non-epileptic seizures and functional movement disorders. Why do some patients develop this and others develop that? No clue, no clue. And when we speak about these medically unexplained symptoms, do we mean that they are psychiatrically explained? I have yet to see the psychiatric explanation to this. And to say that this poor woman or man had been abused sexually 30 years ago and now they develop these symptoms, this is not really a scientifically valid explanation for me at least. And we should differentiate between the etiology and the mechanism. So the etiology, when we speak about psychological factors, whether it's sexual abuse in childhood or repressed conflicts or whatever, is not really relevant. When we treat a patient for their epileptic seizures, we don't care whether it's due to a brain lesion caused by trauma or by genetic malformation or whatever. We try to so we treat not the cause. We cannot undo the trauma that occurred to the brain. We need to treat the consequences. And therefore, the mechanism of the ongoing abnormal activity in the brain or in the soul, and we'll come back to this differentiation soon, the mechanism is completely unknown. But this is, of course, what is essential for treatment. In the context, to come back to the excellent talks that we had just now about the mind and the body, and the context is that the mind affects the body. Physical symptoms respond to mental stress states. This we know. I mean, if we are if we feel under stress, of course we'll feel tachycardia. So there is no, and of course, hypnosis is all about this thing that we can influence the body by affecting the mind. And of course, also vice versa. Mental effects have effect on physical symptoms. So placebo effect is an example, excellent example, where the mental changes can affect the physical symptoms. So to say that it's all in their mind of these people who have the functional disorder is a manifestation of the mind-body problem, and we've heard about monism versus dualism. So if we say that this is due to the mind, if we as neurologists tell the patient or talk to each other and say it's all in their mind, we are dualists. Because if we say that it's in the brain, then why should we refer to a psychiatrist? Then we know about the brain more than psychiatrists. But if we say go to the psychiatrist, we mean it's in your mind. Mind separate from the body. We are dualists when we say this. So with this, bring us back to Descartes, René Cartesius, and to Baruch Spinoza. And I think Baruch Spinoza was the one who really said, dualism is out of the picture. We should be monists. And of course, as neurologists, we know that what we call the mind, whatever we call it, is dependent upon the brain. It's a reflection of brain activity. And is it a separate entity then? And of course, Descartes would say yes, and Baruch Spinoza, Benedict Spinoza would say no. So what about the treatment now? What do we do with these poor cases? And they are really poor patients. There are many of them, and they are dysfunctional, and they come to us for advice and for treatment. What can we do? So many different treatments, serotonin reuptake inhibitors, or give them insight. So we tell them, look, it's not serious, it's not really serious, it's not really a seizure, it only looks like a seizure. Don't be afraid. It's all because you are in stress or whatever, or we can't explain it, but we can show you the videos of your seizure, and you will see that the EEG does not show any epileptic activity. Be quiet. Why do you come to me? Why are you worried? Cognitive behavior therapy, mindfulness, EEG biofeedback, all kinds of medication, and none of them are effective. There is a Korczyn collaboration report about treatment of somatoform disorders, and it really shows that none of them are really effective. So in conclusion, I read this paper from 90 years ago, and I see that our understanding has not improved at all. We still do not understand now what our forefathers did not understand 100 years ago or so. Medically unexplained is actually a euphemism. When we say medically unexplained, we really mean that it's unexplainable. Because of course it's not medically unexplained. Of course nothing in science is completely explained. But here we say it's beyond it. It's beyond the technical issues that we cannot explain these things now. We shall never be able to explain them. This is the subtext when we talk about medically unexplained. It's all in your head, or your symptoms are not real, or these are pseudo-seizures. These are derogatory attitudes. And we should never use them. For the benefit of our patients, this does not help at all. Most important, we should realize that the patients really suffer and should not be stigmatized. That giving patients disorder a name, like fibromyalgia, may help them, but should not confuse us. So I don't believe that there is a disease like fibromyalgia. But if a patient comes to me and say, I have fibromyalgia, what can you do to me? I don't start to argue with him or discuss with him, what do you mean by fibromyalgia? The patient was relieved by the fact that he was given this diagnosis, more than if everybody would say, we don't know what causes it. Now there is a name, it's a legalized name already, so maybe we should not try to antagonize him. And it is probably wrong to identify medically unexplained symptoms of depression or anxiety. If patients are depressed, it might just be secondary. And the take-home messages. Diagnosis of medically unexplained symptoms is made by exclusion. As a diagnosis made by exclusion, this diagnosis should be made with great caution because prospective studies show that some medically unexplained symptom cases turn out to have an organic disease. And these are very few, but we should be very careful with them. And then there is the issue, the question of who should treat this patient. Is it really beneficial to refer them to a psychiatrist? And I must say that I don't think so. I don't think that any psychiatrist can treat my patients who have medically unexplained symptoms better than I can. And I wait to be disproven on this issue. The assumption that all medically unexplained symptoms reflect psychiatric disease is unproven. Most cases are also psychiatrically unexplained. And the assumption that medically unexplained symptoms has a psychiatric etiology infers philosophically dualism. And I thank you for alerting you to the paradox. We believe that non-epileptic seizures are not organic, yet we believe that abnormal movements are generated in the brain. So if they're generated in the brain, how can we say that they are not organic? How can we solve this paradox? Medically unexplained symptoms are non-organic, yet are caused by brain activity. This is the mind-body division. This is the hard question that we started with, and I don't know that I have an answer to this. I don't know that anyone has an answer to this. I don't know that anyone ever will have an answer to this. This is one of the issues. But if there is an answer, it will come up maybe next year in Warsaw when you are all invited to come and attend the next CONy meeting. Thank you for your attention.